Thank you, Professor Coleman, for a nice talk. And now may I invite Professor Larry Kwak from MD Anderson Cancer Center to speak on targeted therapy for Hodgkin's lymphoma.
Okay. All right, good morning. So it's a pleasure to represent my department of lymphoma and myeloma at MD Anderson. We've been active in research in Hodgkin's lymphoma for quite some time, and I'll share some of those results in the context of the title of the talk that I've prepared, which is on focusing on targeted therapy for Hodgkin's lymphoma. Dr. Coleman actually introduced several of the topics already, but I'll be going into a little more detail and perhaps leaving a little extra time for Dr. Laporte. So, as you've heard already and are aware, in Hodgkin's lymphoma we've been quite successful, and some of the goals for ongoing research are to continue to improve remission rates and decrease the risk of death while minimizing side effects and maintaining or prolonging remissions. There is still an unmet need, though, to develop for patients who have relapsed or refractory disease, as you've heard already, and that for those patients we need to develop additional therapeutic options. For example, those patients who have failed stem cell transplantation. So I'm going to introduce several targeted therapies and give you somewhat of an overview and give you some insight into mechanisms and directions. But the first is the development of a deacetylase inhibitor in Hodgkin lymphoma. And this effort was led by Dr. Anish Yunus, who had led our Hodgkin's lymphoma research for many years. And in collaboration with Dr. Youngjun Liu, who was the chair of immunology at MD Anderson, they made a couple important discoveries regarding deacetylase inhibitors. And what they did was they demonstrated that there were actually two mechanisms for anti-proliferative activity for these deacetylase inhibitors in Hodgkin's lymphoma cell lines. First of all, a direct effect on the tumor cell by induction of cell cycle arrest and apoptosis. But importantly, they uncovered a very new indirect mechanism which involved the immune system by downregulation of a chemokine called TARC or CCL17, which represented alteration of the microenvironment, and that's shown on this picture. So you've got both the direct effect of deacetylase inhibitors, exemplified by SAHA and the methylgene product, acting directly on the Hodgkin's Reed-Sternberg cells, but also in another indirect mechanism, downregulating this chemokine, which normally functions to induce T helper 2 cells to deliver growth signals or survival signals to the Hodgkin's Reed-Sternberg cell. And so by blocking this pathway as well, they elucidated the mechanism of effect and provided additional rationale for the use of histone deacetylase inhibitors in Hodgkin lymphoma. So in part, these results, preclinical results, led to a single-arm phase 2 trial which was published recently, of an oral HDAC inhibitor made by a company called Methylgene in patients who had been previously treated in multiply relapsed patients with Hodgkin's lymphoma. And this is one example of a patient from that study. Extensive, as you can see, extensive prior treatment, including transplant, an allogeneic transplant, and this is the PET scan before and after treatment on this trial. There were 51 patients on this study, and importantly, they tied the mechanism of action back to the inhibition of TARC levels as measured in the plasma of these patients. As you can see here, they correlated plasma TARC levels with the clinical responses and showed that there was a correlation, suggesting that this might be a potential biomarker to guide future clinical trials with these agents. And this is fairly typical of the type of clinical research that we do at MD Anderson, in which we are trying to learn something about mechanism at the same time we're observing patients for clinical response. So in part, this line of research also led to a phase 2 international study of another histone acetylase inhibitor called penobinostat, which is a pan-HDAC inhibitor. And these results were published in the Journal of Clinical Oncology last year. This is the waterfall plot showing 71% of patients had tumor reduction. These were also heavily pretreated patients with Hodgkin lymphoma. And so this is quite a promising area of drug development for Hodgkin lymphoma. I think you're going to see more pivotal trials with those agents. Now, moving on to antibodies. Some of you may or may not be aware that there is a long history, actually, of trying to target CD30 receptor on Hodgkin lymphoma Reed-Sternberg cells. Many years ago, there were a series of naked antibodies directed against the CD30 receptor on the Reed-Sternberg cells. But these, as shown here, there are 3 separate ones here listed, here, summarized here. Most of these had really very modest, minimal to modest effect in terms of clinical responses. So it was somewhat surprising, actually, that the immunotoxin conjugate, SGN35 or Brentuximab Vedotin, had such dramatic activity in this disease. But again, you've seen this slide before, but basically this is an immunotoxin, which is in which the antibody against CD30 is conjugated to a microtubule disrupting agent. And the way immunotoxins work, this is really a success story for immunotoxins, probably one of the first ones to really show clinical activity. Even though the idea has been around for a long time and scientifically there's been much promise in preclinical studies. But the idea is that the antibody binds to the CD30 receptor on the surface of the malignant cell, in this case the Hodgkin Reed-Sternberg cell, and then basically is used to deliver the toxin internal to the cell, where it then can gain access to the microtubule network and disrupt it. So Dr. Coleman's already introduced the traumatic clinical responses that were observed in early studies of this new immunotoxin. This is a summary of the phase 1 results showing, again, I'll just highlight 86% tumor regression depending on the dosing. Really dramatic results, which is now all part of history. And this is the waterfall plot from the phase 1 study. Also showing about 81% of patients achieved tumor reduction. So the pivotal trial, as you all know, was published recently and led to the approval of this drug in Hodgkin's lymphoma. Was done in 100 patients who were heavily pretreated. Most of them were refractory to frontline therapy, and over 70% of them had relapsed within a year after autologous stem cell transplant. The conclusions from that pivotal trial were that there were multiple durable complete remissions obtained, again, in heavily pretreated patients with manageable adverse events. And this, again, this collection of data led to the approval of this drug last year for Hodgkin lymphoma. So Dr. Coleman also introduced the topic of how to improve on frontline therapy, and I'm going to go into just a little more detail here in the effort of the next step to combine Brentuximab Vedotin with ABVD chemotherapy, as was presented by Steve Ansel and other collaborators at ASH. So I think the rationale is already fairly clear that treatment-naive patients with Hodgkin's lymphoma are treated with standard of care, which is ABVD, and it generally yields a very good complete remission rate. And you've seen that single-agent Brentuximab Vedotin in relapsed patients has shown an objective response rate. And so it's natural to combine those two drugs up front. This, again, is the design of the phase 1 multicenter dose escalation study with these objectives to assess the safety profile of Brentuximab in combination with ABVD and AVD, and to look at tumor response rate. So these are the dose cohorts that were used. These patients were advanced patients with advanced stage Hodgkin's lymphoma. Many of them had bulky disease, and over 25% had high IPS scores. So these were not just favorable patients. In terms of adverse events, which was an important endpoint for the study, I'll focus in on this issue of pulmonary toxicity that Dr. Coleman introduced. Specifically, if you looked at all patients with any event from pulmonary toxicity, there's a striking difference between patients who received bleomycin in the induction regimen and those who did not. And this was, and in fact, there were 2 patient deaths that were associated with pulmonary toxicity. Peripheral neuropathy also was significant in these patients, although most events were grade 1 and 2, with no grade 4 or 5 events, and not really much difference between the 2 arms of the study. Let's see. And again, as Dr. Coleman introduced, the response rates were excellent. We're looking at 95+% complete remission rates, which certainly would be better, at least as good or possibly better than ABVD alone. And so the conclusions from this combination study were that concomitant administration of Brentuximab vedotin and bleomycin is contraindicated due to pulmonary toxicity. Again, as you heard, the recommended regimen is 1.2 milligram per kilogram every 2 weeks combined with AVD. AVD combined with Brentuximab vedotin appears to be well tolerated with manageable adverse events. And the complete remission rate of 96% observed at the end of frontline therapy with the combination provides the rationale for going forward with a phase 3 study that is now ongoing, testing this combination of Brentuximab plus AVD compared to ABVD alone in advanced stage patients. So my final slide is just to acknowledge the investigators in our Hodgkin's lymphoma working group. Again, Dr. Yunus led this group for many years, and now this is led by Dr. Michelle Fanal, who provided me with many of these slides. So with that, I'll close, and thank you for your attention.